Hello, everyone. My name is Ros Glasspool, and I will be your moderator today. I'm a medical oncologist, and I specialise in the care of women with ovarian cancer. I work in the Beatson West of Scotland Cancer Centre in the UK, and I am absolutely delighted to welcome you all today to our virtual patient perspectives roundtable. This is the third in a series of 4 roundtables that's been sponsored by GSK. And today we're going to focus on survivorship, quality of life, and patient-reported outcomes. We've got an absolutely fantastic panel, truly international, and I'm really delighted to say that we had over 100 registrants from 40 different countries, which I think just speaks to the efforts of IGCS. We want to connect women and their caregivers around the world to give a stronger voice, share our experiences, our best practice, ideas, problems, and we really want to be able to contribute to what we see as a global need for vetted, constructed region and population-specific information and guidance. So thank you so much for joining us. There are just a few housekeeping things related to Zoom. You can adjust your view by clicking the view button at the top of the screen if you want to see the speaker, if you want to see all the participants. So there's a gallery view. We'll be doing that particularly in the Q&A session. We know that sometimes everyone's video is not always perfect and it's dependent on your internet connection, but don't worry, this session is being recorded, so you will be able to watch it back on the IGCS website if you do have any problems with connections. And we absolutely encourage you to submit questions through our Q&A function, and we will try and address as many of those as we can at the end. So it's my honour to address, that was the technical bit, to introduce some of our incredible speakers. We've got Sally Kawenda, a patient advocate, HIV and AIDS counsellor, and a member of the Non-Communicable Disease Alliance Kenya, and a global hero of hope in Kenya. We have Sharon Mann, a clinical psychologist, professor of medicine, chief of behavioural science, and founder and co-director of the Centre of Excellence in Cancer Survivorship at the Reuters Cancer Institute in New Jersey. We've got Ramunda Correa, a gynae oncologist in palliative care and subspecialist as well, and a physician from the Hospital of Santiago Oriente and Clínica de las Condes, Chile. Sorry, my accent's not very good. And Eva Maria Stromsom, a patient advocate, nurse, teacher, and co-founder and vice chair of gynecological cancer patients and a member of the board of the Cancer Society of Finland. So as you can see, it's going to be a really exciting session, and I'm really looking forward to all these presentations. Just very quickly, just wanted to make a few comments myself. So as we hopefully improve our treatments and as people around the world live longer, we are also seeing more and more people living with and beyond cancer. And it's really important that we now consider how best to support them. I think as clinicians, we've always been very focused on treatment and the immediate toxicities of those treatments, but we also need to consider the long-term consequences of treatment, which can be pain, neuropathy. There are very specific things for women with gynecological cancer, like menopausal symptoms, impact on sexual function and fertility. And I think another really important area is helping women to adjust back to what is their new normal after a diagnosis of cancer, and dealing particularly with fear of progression, which, although a very realistic fear, can become very overwhelming and impact on quality of life. I think also is a question of how we integrate palliative care and symptom control into oncology practice from the beginning. I'm very fortunate in the hospital that I work in because we do have an integrated palliative care team, and I work with them every day. We have joint ward rounds. And so when women come in with ovarian cancer, often with very difficult symptoms when they're first diagnosed, they're with me, seeing them right from the beginning. And I think that's very important, both for individual care, but also in training myself and my trainees. And I will always remember one of my oncology colleagues who described herself as a palliative care doctor who also gives chemotherapy. And I think that's actually a very important way of thinking about ourselves as oncologists. I'd also really keen to talk a little bit about integrating patient-reported outcomes into everyday practice and how we can make the most of patient-reported outcome data. We know that it provides prognostic information, and we know from the landmark study by Bash that the integration into routine care during treatment can actually improve overall survival. it's just a question of how we best use this. And we've been using them and investigating them in research for a long time. And I still don't think that we've really got on top of necessarily the right tools and the right questions. And so actually introducing into everyday practice has maybe even more challenges. We now have technology that can help women to report these things, but we need to think about how we actually interpret that data. We can't be looking through pages and pages of long questionnaires in a busy practice. So how can we really distill that information, look for modifiable factors and identify those who are maybe most at risk, that need the biggest support to help them improve their quality of life, particularly addressing those in vulnerable communities who maybe don't have the loudest voices themselves. And I was very interested working with one of our professors here who works a lot in prostate cancer, actually, and they found that men often don't talk about their problems, and they didn't want to report any issues even to their healthcare providers, but they would chat online, they would enter information online. And so they used some patient-reported outcome measures to then develop an online holistic needs assessment that allowed men to direct themselves through and opening up pages with guidance and signposting to help, but at the same time in the background a red flag system that identified any majorly important symptoms to their healthcare team. So these kind of things are all possibilities, and I think will be very interesting in the future. It's just a little bit of information about some things that I've been involved with in the UK. I've been very privileged to be involved with the Macmillan's Horizons programme, which is a longitudinal project aimed at identifying factors that are associated with recovery, ability to self-management, and to try and identify those who are going to need more support. It's gone across different tumour types, but we have a cohort of women with gynecological cancers, and over 1,200 women have very kindly volunteered to be part of the study and to fill out questionnaires going on over a longitudinal period of time, which I think makes it very, very valuable. And I'm hoping we're going to be able to publish the first results of that, and indeed identifying identifiable factors. I was also involved in the OVPsych study led by Professor Blagden from Oxford, where she investigated fear of progression and demonstrated that this is amenable to cognitive behavioural therapy, which can really help support women, but we do need to maintain that support over time. And I'm also involved with the Explorer study, which is a real-world study looking at outcomes and patient-reported outcomes in women with ovarian cancer treated with rucaparib, which is an oral PARP inhibitor. And we are investigating some different quality of life questionnaires, because I felt that many of the things didn't really seem to address things that were important to women. And so one of the questionnaires that we're going to be looking at is one developed by Dame Professor Fallafield's team, which will look at the impact on women's roles and responsibilities, because I feel that's what people want to know. Am I going to be able to go to work when I'm on this maintenance treatment? Can I look after my grandchildren? And how is it going to impact my everyday life? And we're also going to study fear of progression whilst women are on maintenance therapy, and look at their expectations of treatment and see whether those are realistic and how that correlates with decisional regret, because I'm also interested in developing decision aids to help women when they're making those decisions about ongoing maintenance treatment. So without further ado, I'd like to move on and introduce our first panelist, and that is going to be Sally Kwenda from Kenya. So Sally, please just start your talk. It's lovely to meet you.
Thank you so much, Rosalind. I'll say hello because it's different timings. For example, in Kenya, we're just ending the day. Some people are waking up, some people it's late night. So I'll just say hello to everyone. So my name is Sally Agalo Kwenda. I'm a patient advocate for HIV and cancer. Growing up, I really wanted to be a doctor, as my father was. But me and mathematics were not friends. So I did not get that opportunity to get a straight A to be a doctor. But I'm glad that most people now call me a doctor because of, I call myself a QBE. I'm qualified by experience. And the experience I've had is because I'm living with HIV since 1999. And I've also survived cancer 3 times. And because of this, I'm now a patient advocate for the 2 illnesses. So I was diagnosed with cervical cancer stage 2 in 2007, and I had to go a total hysterectomy surgery. And this was very traumatic for me because I'd already lost 2 babies from HIV-related illnesses. So I must say that I thank God for doctors and what you do and the surgeons, but sometimes the way the news is broken to a patient is very harsh. And sharing my experience, I was just told, you have stage 2 cervical cancer and we have to remove your womb. I was not given an opportunity to even digest the news. So when I asked this doctor, he said, we have to do this because you already have HIV. And so if we risk leaving you like this, you have the kind of cancer that may spread. I didn't take it so easily, but anyway, because it was going to save my life, I opted to do it after. Of course, anyone else would go for a second opinion, third opinion. But finally, after talking to also some of the colleagues, I was working in a medical organization, they told me, Sally, that is the best decision that you can make. It is a tough one, but please try and make that decision. I had no choice. And we signed a consent with my husband. And I went to theater and I did the total hysterectomy. Unfortunately, my husband couldn't take it. And after a few months, he left. And he openly told me that he cannot live with a woman who cannot give him babies. And I faced a lot of stigma from my in-laws and many people. But I thank God that I had a family who really stood by me. And I must thank one of my sisters who said she will walk with me in this journey. And to date, she has held my hand. And many other people, my friends, my colleagues, and I'm so grateful for this. Unfortunately, after the total hysterectomy was done, and because I had very low immune system, for those of you who are familiar with HIV, we know that what is really checked is the white blood cells. I only had 30 at the time. And so the recommended treatment for me for cancer was surgery because I could not go through chemotherapy or radio because of the already compromised immune system. And so I had surgery many times. I've gone to theater so many times, and the number of times I can count is up to 13. The rest I can't even remember. The doctor assured me that you'll go through a lot of pain, but I will try to manage it. But that is the best option because you're already having HIV with a very low immune system. So if we try to do chemo and radio on you, we may lose you. So I must thank this surgeon who was very frank and open to tell me this. Unlike the other one who just told me you have HIV and you have to do this and without counseling. So I opted for that, but unfortunately after 3 years, the cancer again, I got a recurrence in the colon and it spread to the rectum. And so from 2010, I've been having what is called an ostomy. I have a special passage for my stool. That again comes with a lot of stigma because I have to walk around with a colostomy bag. And a lot of people, for example, in my country, Kenya, they are not aware of this. And so even the appliances are not available. And if you are lucky to find one, it is very costly. And as a patient advocate, meeting these patients every day, I've found that a lot of patients are dying from chronic conditions, not even from the chronic condition because of how they're treated, or again, they're not able to access the appliances that they need. When we're talking about cervical cancer, there's discharge that comes with it. And for me, it needs a lot of palliative care. And a lot of women are not given this information. And you find that, again, data is not given. For example, for cancer, in my country, Kenya, we are told that 9 women are dying every day from cervical cancer. But they're not saying that there's a Sally somewhere and someone else and someone else. If this data could be given, then a lot of women would go for the screening. I find that many women fear to go for the screening because they say cancer is a death sentence. So if I go and get screened, then I'm dying. But if they can get some information, and like I share my story a lot, and I'm humbled that I can share it once again today. If we can be given data on survivorship, how many women have died and how many women have survived, so that those who have not gone for screening can have that hope. And so to me, life has not been easy, but I've chosen the positive side. So I share my story to inspire people and to encourage those who are losing hope. And I use my story also to create awareness on cervical cancer. And I say that no woman should die of cervical cancer. That is the message that I always put forth whenever I'm speaking. I'm 51 years old today. And 41 years ago, I was 11. I'm not so sure if the HPV vaccine was there, but I was not privileged to get that jab. And I suffered the pain of cervical cancer. It is pain that I didn't want my worst enemy to go through. And that is why I speak and say that if you have a girl who is young, please take them for that vaccination. Cancer is painful, and I wouldn't want anyone to go through this. My message to any policymaker who's listening to me today is this. For the survival of every young girl, there is need for the HPV vaccine. And as I said, I suffered tormenting pain from cervical cancer. We can avoid it by creating awareness and people going out there to get screened early enough. I would also kindly request that we improve on the care provided at our comprehensive care clinics for HIV to include cervical cancer. There's a lot of nice things, nice policies written on documents, and they're put in shelves. I'll give an example of my own country. They are not implemented. In the HIV clinic that I attend, you walk in, you're given your antiretroviral treatment, and you walk out. If every woman could be screened for cervical cancer, the numbers that we are talking about would not be there. And as again, I would want to emphasize that we have data on cervical fatalities, but none on survivorship. If this could be shared, it could give hope to a lot of other women. As it is now, a lot of people still believe that cancer is a death sentence. So being a patient advocate, I realized that stigma is a result of lack of information from the community, and training of community health workers is key, whereby the information can be shared with the patients together with their caregivers, and the community at large would not stigmatize one another. I realized that sometimes stigma is lack of information. People don't know how to handle you. For example, if I can give my own story, is when I got my ostomy, I was employed by them. And I couldn't go to work for over 6 months. I was staying at home because people didn't know how to handle me. My colleagues were wondering, how do you come to the office with a bag? I was doing field work. How do you go to the field and see patients with a bag hanging on your side? So because of lack of information, they didn't know how to take care of me. And so I wasn't able to go back to work. I had to stay in hospital for 2 months because my family didn't know what to do with me when I went home. So I'm not saying this to get sympathy from you, but just to know how difficult life would be for some of us who are living with chronic conditions. So palliative care is not all about end of life care, but should include mental health issues. People living with chronic conditions, and especially cancer, need a lot of psychosocial support. And many women are dying not necessarily from the diseases, as I've said, but most of them are dying from depression. And as a result, some of them are even committing suicide. Some young women are diagnosed with cervical cancer. And so after they're going through the treatment called brachytherapy, a couple of them, when I talk to them, they say they can't enjoy sex anymore. and some of them have a discharge that is never ending, and it's very annoying, and it's the smell, you can't even stand it. So the list of all this is endless. I would like to say also that in accordance with the greater involvement of people living with HIV, the GPA principle, and the WHO framework on integrated people-centered health services, people living with HIV and NCDs should be meaningfully involved in the planning, implementation, and monitoring of all interventions to safeguard and improve their health. Thank you for listening to me.
Sally, thank you so much for sharing your story so bravely. I think it's just an incredible thing to do, what you're doing, and I'm sure it's actually brought up a lot of questions that we would like to come back to at the end. I think you're a beacon of hope for people, as you say. And
yeah, I'll be happy to answer.
That would be great. Well, I'm going to move on just now, and then we'll come back and have questions at the end. So I'd like to now introduce Sharon Mann, and I hope Sharon's able to share her screen.
Hi, I'm Sharon Manny. I'm from Rutgers Cancer Institute, and clearly I'm not good at slide sharing. I'm a psychologist, and my area of expertise is psychological adjustment to cancer. For the last almost 20 years, I've been working with gynecological cancer patients with 2 different R01 trials and a third underway at this point in time. So I'm going to share just some of my experience working with this population. So as most of you probably already know, distress is relatively prevalent among women diagnosed with gynecological cancers, with rates really varying depending on how the issues are measured. But generally speaking, depression is high at the beginning of treatment and then resolves for most women if we're talking about clinically relevant, clinically significant depression. Anxiety, though, does increase over time, but does settle out over the course post-treatment. So cancer-related distress, as our prior speakers have talked about, and I want to focus on a little bit today, is a longer-term concern. So while anxiety and depression may be elevated at the beginning of the treatment and diagnosis process, traumatic stress related to cancer is there at the beginning, and then it actually does stay elevated for a subset of women. I'll talk about that in a moment. Also, fear of cancer recurrence, as our speakers have spoken about, is in the mild to moderate range for about half of our population, with health and death worries about passing away from cancer being the most common fears. Unfortunately, the use of psychological services in the populations, at least in the studies that I reviewed, is pretty low. 68% use one or more services, but the most common service used is psychotropic medications, which are usually for sleep. So you can see like really low rates of utilization of care given the relatively high rates of distress. In my work, I've looked at the trajectories over time, over 18 months, of women that have gynecological cancer. And we found about 50% over the year and a half after a new diagnosis do evidence high, stable, global fear of recurrence. And that is just general thoughts and worries about the cancer progressing, obviously, in ovarian and other late-stage cancer, and then recurring in the early-stage patients. So you can see that for the other types of fears of recurrence, womanhood worries, which are common in this population, about 15% stay high. And then in terms of health worries, about 80%, of course, have high levels of that, and then it stays pretty high over 18 months. There are very few evidence-based psychological interventions that have been developed and evaluated for this population. I'm talking about published work, not unpublished work at this point in time. About 6 studies have demonstrated reductions in distress and improvements in quality of life. 2 studies haven't had effects. 1 study had some mixed effects depending on the outcome, and all but 1 was delivered in person with a small recent online psychoeducational intervention with 10 weekly meetings showing some preliminary effects. In terms of the work that I've been doing for the past probably 15 years in psychological interventions, I've developed and looked at 2 types of interventions. One is a cognitive behavioral intervention called coping and communication, and one is a supportive counseling intervention. And I've looked at it and compared it to usual care. And since my area of research is looking at how people react and the mechanisms of change for our interventions, we've been looking at that. My work to date, up until my most recent trials, looked at newly diagnosed patients that are more functional. They've been studied over a year and a half, and we have 7 in-person sessions and a telephone booster. This is the CCI intervention. If anybody wants to look at the intervention in detail, it was published in Gynecological Oncology a couple of years ago, 2017, 3 years ago. Basically, it's coping skills. So coping skills practically, problem solving, emotion focused coping skills, communication and garnering support, dealing with worries about the future, sexuality, intimacy, and body image, and then enhancing self-care, and then reviewing the skills that they have learned, and then a check-in. So this was done on a one-on-one for the original trial, and compared to supportive counseling. Supportive counseling was just what you think. It's basically being there to support self-esteem, being there to form a strong relationship with the patient. And in my second study, we did develop some themes of the work and try and do a little bit more in emotion processing. That means getting the patient to become a little bit more aware of her emotional reactions so that she can talk about them and process them. So relevant to some of the work that was talked about earlier, my work has not shown an impact on fear of recurrence. It does show an effect on the Beck Depression Inventory, on cancer-specific stress, which is the impact of event scale, and it shows an impact on emotional well-being. But as you can see here, CCI does show some effects, but they really does bounce back on fear of recurrence, obviously showing that our intervention isn't really working so well. So what have I done with this work? So after I finished the original study, I became extremely interested in fear of recurrence and what drives it and what the differences is between people who have a fear of recurrence and people who do not. So what we found is that, you saw the slide a couple of minutes ago, women in the high stable fear of recurrence group reported more depression and more cancer distress. They held back sharing their concerns more with others. They have lower coping efficacy in terms of dealing with the stressors that they encounter during treatment and after, and then they compared to women in the low stable group. So the group that has high fear of recurrence has some different coping and patient-reported outcomes at the beginning of treatment. As I said before, about half of survivors do experience elevated and persistent global fear of recurrence, which is, in my work, been strongly associated with depression over time in longitudinal studies. So the implications here are that focusing on holding back sharing concerns and garnering better support for your concerns with those in your social network and fostering confidence in coping with cancer-specific stressors may impact distress. So again, I did another study looking at what may drive fear of recurrence. So by understanding what may make patients report more depression, how fear of recurrence relates to depression, will help us in formulating a more effective, or at least I hope, a more effective intervention. So what I did is, this is just a structural equation model, and what I did is looked at fear of recurrence and how it related to depression and what coping strategies were related to more or less depressive symptoms. So we looked at holding back, negative responses from family and friends, coping efficacy, reappraising cancer in terms of looking at some of the positive effects of it, which just seeing it as something that, for most patients, encourage growth, or setting your priorities. So those are some common examples what our patients will look for to try and reappraise the situation. And then just general self-esteem. And what we found is that holding back, again, so not sharing your concerns with others, feeling more isolated in your concerns and not sharing them, and self-esteem appraisals mediated the risk between fear of recurrence and depression. So the implications for the next study was to help women share their concerns with supportive others. So now I'm going to talk just a little bit about the new study, which I've been working on for the past 2 years. Because our population, at least now and more so with COVID, is not coming as much to in-person therapy. So I migrated our content to an online format. given our population is relatively older, we did it with a more usable, ostensibly usable intervention where all the intervention content was a click on. That can be done on the phone, it can be done on an iPad, it can be done on a computer. What I did is I made 8 different modules, and there were 4 bi-weekly telehealth sessions. So what I'm doing is the patients are doing the online content, and then afterwards I'm reviewing the content and tailoring it for their specific concerns and needs, which I've outlined both on the online version and in the therapy sessions. Then I do 2 follow-up sessions spaced 3 weeks apart. After they end the treatment with the online and my sessions, what I did is I split up the emotion-focused coping content into 2 sessions. The first one was more just generic cognitive behavior therapy. So for those of you who are familiar with this is thinking about your thinking, trying to find any cognitive distortions, which in this case aren't too many because obviously some of the fears are very rational fears. But we do look at some of the other cognitive restructuring techniques that help the patient focus on any different reappraisal of any problem that she encounters. The second is more acceptance and commitment therapy, which is a very well-known and evidence-based treatment for depression and anxiety. In this case, it's to foster emotional awareness, acceptance, and psychological flexibility. The goal here is, of course, not to change the fear of recurrence or to label it as irrational, but to allow the patient to sit with the fear with enough awareness and tolerance for the feelings to for some patients it passes, and for some patients they see it as a cue to engage in more self-care. I can talk a little bit about that if anybody has any questions. The pre and post survey was done for this with measures that I'll talk about in a moment. We have 10 patients enrolled, 4 patients are still in process. And I should just point out that the depression levels are relatively high, about 60% mild to moderate depression, 10% severe depression. Our sample, because I work in a cancer center, which is in a really diverse state, and it's the state's cancer center, does have a little bit more of a diverse population in terms of, particularly with regard to education. So this is what we designed for the Journey Ahead study. So the first 2 online sessions are more about gathering information that we feed back to the patient by giving her some tailored content on what her goals are, what her major stresses are. The first intervention module is coping with stress. Second is thinking about the third session is thinking about our thinking. The fourth, as I mentioned, is on acceptance, prioritizing values, and working on figuring out what's important to you now versus what's important to you before cancer. The 5th session, which is relevant to everyone, is communicating, and this is where I focus a bit on holding back sharing concerns. The 6th session online is, again, the body image session, and then worries about the future, putting it all together. There's a check-in module that is yet to be developed, just because everything that you develop online, you cannot walk in the door for less than $100,000 to develop an intervention online nowadays, and then it becomes outmoded within 3 years because they change their platforms. So I still haven't done the development of these last 2 online sessions, but for my check-ins, I do a review. I first check in on her mood, obviously, check in on her progress on her goals and any challenges, and then I discuss typically any of the challenges of fear of recurrence or the themes that we've talked about in terms of coping skills. So what are the results to date? As with most pilots, we had about a 25% acceptance rate. I'll talk about that in a moment, but our effect sizes are really strong. What that means is that we have a 1.0 is like extremely strong effect size. So we do have an effect on depression, on cancer-specific distress. We found increases in well-being and decreases in holding back, which I think is really promising. And then increases in emotional expression, acceptance, and self-efficacy in managing cancer. What you'll note about this is that it received really high ratings, and I was happy to see that, but I do want to talk in a minute about my clinical opinion about sort of what the pluses and minuses are with online telehealth and combined with online and telehealth together. So our population does tend to be underserved given their distress levels, and online interventions have greater reach. 15% of our population, though, refused the trial because they were not, well, they didn't refuse it. They weren't eligible because they didn't have home internet access. Even among those patients who had online access, had significant technical challenges to the online interventions and to telehealth. And what I mean is Zoom or WebEx. For about half the patients, I am doing phone counseling, not telehealth sessions. And this is even with a project manager who reaches out and orients the patient to the online intervention. She works with them, tries to get them, but they still have trouble accessing the online portion, and then they have access with the telehealth. Our patient population does experience distress with a really difficult treatment trajectory, as we all know, that is frequently characterized by recurrences and a high risk for progression. And so I have seen of our 10 patients who are currently in therapy, 2 people have recurred even while there's being seen by me, which is in about a 2-month period of time. And my success in getting uptake of psychosocial care, which is part of my telehealth, is relatively low. Pointing out that it's really important to intervene early and obviously during critical disease progression transitions, which for our population at the Cancer Institute are even when I'm seeing them on treatment. Again, I want to reiterate what everyone else has said about our population. Teaching skills, as I do in my sessions and on the online intervention, clearly helps reduce depression. But we need to offer this throughout the disease trajectory. We have to find a way to access our patients throughout the disease trajectory, because just allowing them to have access, like for example, the Journey Ahead's been great, but my grant, ultimately will not allow me to follow patients longer term if I get funded again. Again, the last thing, reducing fear of recurrence may be difficult because it's a rational concern. I do want to point out that the majority of people who study this phenomenon think that it should be best to reduce the fear. My general approach to this is more acceptance and commitment based, that we teach skills to manage worry, particularly ACT, values and acceptance-based living, that this is really important to talk to the women about managing negative affect, managing the fear, not getting rid of it, because it's a very rational fear, and I don't think it's realistic or a good approach to tell somebody that they shouldn't be afraid of what might happen. I do want to point out that value-based living is the most important coping strategy that I work with. Our population are mostly stage 3 and 4, but we do have some earlier stage patients. But even in these patients, I really do work on values, what's important to the patient, working on what her priorities could be, which of course are very changed over the course of treatment. And I'm sorry I rushed through this. I'm probably ending early. Thank you.
Thank you, Sharon. That was really very, very interesting, and I think we'll prompt lots more questions. But for now, I'm just going to move on to, in the interest of time, to Raimundo Correa from Chile, who's going to tell us a little bit more about integration of palliative care.
Well, first of all, thank you very much for inviting me. Thanks, Daisy, for organizing this roundtable series. I think this topic is very, very important. And now I will give you my perspective about the evolving concept of palliative care. When we speak about cancer survivor, we speak about the patient from diagnosis through the through the rest of her life. It's not the person who has been cured of cancer. Cancer survivor is from the diagnosis. So some patients will be cured, some patients unfortunately will die of the disease, and we need to take care of all of them. This is a human right for the patients to be seen in all over the disease, not only in one part of the disease. Also, we are not looking at cervical cancer. We are not looking at the cervix of the patient. We are looking at the patient as a whole. So that's the importance of a multidisciplinary approach. And palliative care has been named before in this today, but palliative care is not intended for end of life exclusively. I will show the the evolving concept of palliative care right now, and also I will try to convince you about the importance of early integration as part of a continuum care. The definition of palliative care, the WHO definition in 2002, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. 20 years ago, they didn't know about the importance of palliative care during the whole trajectory of the disease, but they put the importance, they gave importance to the multidisciplinary approach. Let me. In 2014, WHO gave the importance of palliative care as a component of comprehensive care throughout the life course. So during the 67th World Health Assembly, they strengthened the importance of palliative care. So they move on and they gave the importance of palliative care as part of a continuum care, as I said before. Now we are seeing the Olympic Games, so we are familiar with this kind of slides. And I would like to show you the importance of being the whole team, the surgical oncologist, the gynec oncologist, the medical oncologist, the radiotherapy, and the supportive oncology team / palliative care since the start line. I think that's the way we should approach a patient today, regardless the the end of the patient. So we don't know if we will be able to cure the patient or if the patient will die of the disease, but the whole team should be at the start line. I think this is the current approach. This is the 2021 approach that we need to push to have everywhere. I know this is very difficult. I know there is inequity, but that will be our goal. Our goal is to cure the patient, yes, but also our goal is to give a good quality of life. So which is the evidence for supporting early integration? There is a statistic significant difference in symptom intensity and health-related quality of life. And there is a trend. It is not statistically significant, but there is a trend in depression and survival. A meta-analysis in 2019 reviewing all randomized control trials showed a 14% increase in overall survivals for those patients with any kind of cancer, not only gynecological cancers, who were integrated earlier in the course of the disease. When they, what did they mean by early integration? During the first 8 weeks since the diagnosis of metastatic cancer. So now the concept of palliative care is an integration with the specific treatment team and palliative care or supportive oncological team. This is the current concept. And also the care and the role of palliative care does not finish with the death of the patient. There is a role for the bereavement period, for the healthcare, for the caregivers and the family members of this patient. So, which is, I think most of you are familiar with this, the Lancet Commission report in 2017. We know that almost half of the patients who die every year need palliative care. So, but when you speak about palliative care, you are not only speaking about palliative care for oncological patients. We mean also palliative care for non-oncological patients. The access is very unequal. You can see here, this slide shows the morphine access, which is a medication, but represent at some point the access for palliative care services. And we do have morphine in Canada, in the United States, in Australia, but in all over the world, the rest of the world, the access is not an easy issue, and some countries do not have access to morphine. So if we accept that patients are not dying properly, we can say also that the quality of life for cancer patients in the majority of the world is not good at all. And we need to do a lot of things in order to improve this. Following the previous article, the Lancet Commission report launched this article, what means the patient-centered care, and the recommendations were to integrate the concept of patient-centered care. We are not, as I said before, we are not looking at the cervix of the uterus. We are looking after a patient, and we need to look at her completely. Implement routine use of the patient-reported outcomes measures. Integrate shared decision-making and advanced care planning. Involve and assess the family as part of early integration of cancer palliative care. We need to realize that patients are not alone. Patients have family members, have caregivers, and we need to look after them as well, and develop the content and basic method of a standardized care pathway for use as a tool for early integration of palliative care into oncology. This model looks very nice, but I think that I would like to share you my personal model, which is, first of all, convince colleagues and healthcare providers about the importance of including palliative care and early integration as part of the disease team, and also try to call patients and family members to ask for a referral to the palliative care services or to the supportive oncology team. In 2015, the MD Anderson Group gave an orientation about the patient's management. I will give an example about the role of palliative care giving cervical cancer. There is a role for treatment-related side effects, surgical chemotherapy, for example, neuropathic pain, radiotherapy complications, fistula, actinic disease, lymphedema, and also advanced disease, general symptom burden, specific symptoms such as central pelvic recurrence, pelvic sidewall recurrence, persistent heavy bleeding. So palliative care, this multidisciplinary approach, is not only intended for end of life, for the whole disease. This is a patient of mine. She is 10 years free of disease, but she has lymphedema, She also had a necrosis of her hip. She needed a hip replacement. Her quality of life is not good at all. And now it is much better since she started on the, since she has been seen by the multidisciplinary team. And this is a patient with advanced disease. We know, we can see here hydronephrosis. So for both patients, palliative care, the supportive oncology team is mandatory. I will show you two articles related to gynecologic cancer survivorship. I do not have to go into detail. I do not have enough time to go into detail, but this article pointed the importance of gynae patients. They are unique. They have hormonal changes. They have sexual function, negative body image, and infertility issues related to gynecological cancers. And also, this is a recent study, very interesting. They pointed out the importance of sexual quality of life in gynae cancers, and there is a lot of research in advance to do. We do not have enough evidence to show and to increase the quality, the sexual quality of life in our patients. Which are the challenges? Change of mind, names implication. This is not end of life care. This is quality of life, lack of adequate research of palliative care, not only in low middle income countries, all around the world, including quality of life, prompts, and survivorship needs in gynae patients. There is inequity. We need to work on that point. Lack of formal training, loss of hope, and even though I have said to you the importance of early integration, we are still receiving patients very late. Before I finish, you know that IGCS, the focus of IGCS is to be to give an assistant to the whole world for gynae cancers, from the prevention to the palliation. And I am proud to be part of this project. We just launched the palliative care certificate program, which we hope it will be a real help for many colleagues and many health providers. Final remarks. Palliative care supportive oncology multidisciplinary team should be considered as part of the management for any patient with any malignancy. Role should not be necessarily focused in end of life. Proper symptom management and quality of life is key. Palliative care specialists should be part of each tumor board at any place. Now, pandemic has told us that we can meet virtually, so we don't need to be there, and access to palliative care supportive oncology team represent a challenge. Therefore, the development of different strategies is mandatory in order to achieve our goal. Thank you very, very much for the invitation again.
Thank you very much, Dr. Correa. That was fantastic. Huge amount of information and really, really important points that, again, we should come back to. And I think the question of the name is very important. Perhaps we need holistic care rather than palliative care. I'd like to move on now to our final speaker. We have yet another outstanding speaker. So Eva Maria from Strömsholm in Finland is going to speak to us now. Thank you very much.
Hello, everyone. First of all, I want to thank the organizer for inviting me to be in this panel. It's important also to talk about the patient's view about quality of life and survivorship. So I'm really glad to be here. Next slide, please. My name is Eva Maria Strömsholm, and I have had a rare ovarian cancer. I'm working as a nurse, also being a teacher and active patient advocate in Finland and Europe. I have last year co-founded, and I am a vice chair of gynecological cancer patients in Finland. Gynecological cancer patients in Finland is a national patient association which works as an advocacy organization for gynecological cancer patients and their families. We provide reliable information about gynecological cancers and prevention, early diagnosis, as well as different treatments. We give advice, counseling, and peer support to gynecological cancer patients and their families. We also organize trainings and lectures to our members. So we now live in a different world, a different daily life, and a different situation. Despite of the situation with COVID-19, I know that everyone is trying their best to keep up the smile and positive thinking, and that's really important in these days. I got my ovarian cancer in 2008 when I was 27 years old. At that time, I did not know anything about cancers, hospitals, or surgeries. I had been a healthy athlete, competing in half marathon and training a lot. I had no symptoms or no feelings that something could be wrong in my body. At a regular checkup, the doctor saw something on my ovaries, and all doctors thought it was a benign tumor. But the pathology answer after my first surgery told different. It was a rare form of ovarian cancer called dysgerminoma. For me, I remember it was a shock. From being a healthy athlete, training and competing daily, to being a cancer patient. A whole new world opened to me. I had cancer and I had a rare one. After this first surgery, I had to go to another, even bigger surgery, so they could look around if there could be any metastasis left. After the surgery, I was in bad shape. I did not need treatments after those 2 surgeries because the cancer had not spread, luckily. But after half a year, I got really bad pain in my back, and after a while, they did an ultrasound on my kidney and found a big tumor there. I had got a relapse. A third big surgery was done after a year from the first one. They took also away my kidney. The recovery after this third surgery was also extremely hard for me. Then I had to begin with chemotherapy. The doctor told me it would be hard. I had to begin with BEP, bleomycin, etoposide, and cisplatin. I got BEP 22 times in 2 months, and I was I was very ill and in awfully bad shape. I had to get help from my family all the time and support from my friends. It took me half a year to recover and to try to come back to my normal life again, meaning learning to sit again, eating normally, reading books, and watching TV. Next slide, please. A few years after this treatment, I could go back to work, but still suffering from severe fatigue, pain in my back and shoulders, and I got hypothyroidism and got into menopause, having to begin with estradiol. Long-term side effects are quite common for gynecological cancer patients, and with those complications that come along after recovery, it can be hard to have a normal life, and the quality of life is not always so good. Fatigue, psychosocial concerns, neuropathy, lymphedema, sleeping problems, and memory problems are some of the most common long-term problems among survivors, but there are also many other long-term side effects and effects after treatment. It would be good that doctors could discuss about long-term side effects more often and try to help the patients suffering from those. The next slide, please. Today, my life is not the same, but I really enjoy living and I am an active and positive person. I can no longer train and run as before because my body could not do that, so I had to give up my running. I cannot get own children, and this is an issue that should be more often and better discussed with patients before and after surgery and treatments. I suffer from fatigue all the time, and I cannot work full time. I work 50% as a nurse, and it should also be important that the patient get help going back to school or getting back to work after treatments. Some support plan or support to do this, or some plan how to get back to work should be done. The same is about the rehabilitation plan. It is very important that every patient got the individual rehabilitation plan that should consist of physical rehabilitation, but also mental and psychological rehabilitation. I have also been an active patient advocate in many different cancer organizations and associations, being a member of the Council of Finnish Cancer Society, a member of ENGAGE, European Network of Gynecological Cancer Advocacy Groups, and a patient representative, an EPAG in EuroCan, Rare Gynecological Domain. I am a positive and active person who really enjoy life and always try to go forward in this life and see positive things. Unfortunately, I this spring also got another cancer form, thyroid cancer, and just had to try to go through another cancer form as well. It is hard and I will struggle, but I know that with my positive thinking, I could do this to be, I can do this and to be a really good to try to go through this. For the patient's psychological support is really important. Also having the possibility to meet and talk to other patients suffering from the same disease that you are. To have a good peer support or groups where patients can discuss with each other is for many patients a life-saving opportunity. They feel that they are not alone and not struggle alone. The next slide, please. To get cancer is difficult for the patient, not only physically, but also mentally. I have been thinking a lot about psychological support for all patients right after the diagnosis, and I think it is important to give this support to the patient so they can start to cope and understand what is happening. I know that mental and psychological support for cancer patients are important right in the beginning of their cancer journey. Therefore, I last year participated in a cancer challenge in Finland with my idea about the diagnosis curator. The next slide, please. My idea about the diagnosis curator is that the patient, as soon as possible, in 0 to 3 days after the diagnosis, should meet the diagnosis curator. This is because a cancer diagnosis can be a shock for the patient and because the patient can feel lost and overwhelmed, facing the overload of information and feelings the diagnosis will bring. So, how can we do this? When the doctor or nurse knows that there is a patient who is going to get or just has got a cancer diagnosis, they will contact the diagnosis curator about this by phone or by booking system. This should be a normal procedure in the caring process. The diagnosis curator can be a mental first aid for a patient who has just been diagnosed with cancer. The diagnosis curator could be a professional curator, psychological nurse, or similar with experience in cancer care. The diagnosis curator will listen to the patient and also repeat to the patient about things that have been said about cancer and treatments, so that the patient can hear it once more and ask questions. The patient's worst feelings of chaos and anxiety and fear might decrease if it's possible to meet the diagnosis curator in order to clarify her thoughts. The diagnosis curator would be working within the hospital. every single nurse and doctor could be able to contact the diagnosis curator. They would be able to make an immediately appointment for the patient with the diagnosis curator, either by phone or appointment book. If it's possible, the diagnosis curator would immediately come to the ward or the clinic there the patient is. It is important to give time for the patient, to also listening to the patient's thoughts and worries. Next slide, please. I really believe a lot in this idea, and that it eases the cancer patient's fear and anxiety right from the start when the patient gets a cancer diagnosis. It is important that the patient should feel that not only her physical side is taken care of, but also the mental or psychological side. It could be good to have a diagnosis curator in every hospital, helping the patient right after the diagnosis. And thank you very much for listening. Hope you have got many things and many questions. Thank you very much.
Thank you very much, Eva, for sharing your story again. Really, really powerful, and it's really interesting to hear your ideas about a diagnosis curator. And I think now we will move to the whole panel for to address some of the questions that were submitted beforehand and that have come in during this. We've had a lot of questions about patient-reported outcomes and what the best tools might be, and how we can maybe use those both in research but also in clinical practice. I don't know, Raimundo, if you have any comments about particular tools in gynecological cancer patients particularly.
Thank you for the question, Rosalind. We do not have standardized prompts. There has been some, but in order to say that we do have prompts standardized for gynae patients, unfortunately, we do not have. I think we have a long way ahead of us. We have a lot of work to do, and I think we have focused in curing people and improve our survival curves. And I think we have done a good work in most of the cancer types, but now we need to focus in quality of life, symptom management, and prompts.
Thank you. Sharon, did you have any thoughts on this?
Yes, I think it depends on what the purpose is for the patient-reported outcomes. In my work, I've used the Beck Depression Inventory, but it's 21 items. I would very much recommend using an impact of event scale, which is cancer-specific distress. And the third is the fear of cancer occurrence measure. Those three things together give you a good picture as far as levels of depression, and then obviously fear of recurrence and intrusive ideation and post-traumatic stress symptoms. But those are lengthy. And what we've been doing as a field in psychologists in cancer have been going towards, sort of symptom checklists from like a distress screener combined with a problem list. So again, it depends on what your purpose is, right? If you're me, I need to know certain things if I'm treating a patient for a disorder or issues that are important for me to know about, like post-traumatic stress symptoms, avoidance of thoughts, dreams, and nightmares versus depression, and then obviously fear of cancer recurrence. So those are the three things I use, but the PROMIS measures have been very well validated, and they are used in cancer screening populations. There's now a very large trial being done by David Sella between Lurie Cancer Center and in Chicago and University of Miami, using it as a screener, and they're looking at prompts for distress and pain and some other. I think they had 4 things that they were looking at, probably fatigue and sleep, for cancer patients in general. I do believe that social determinants of health are really important. And I have to say, one thing that has come to my attention during my time with my patients recently has been financial hardships. Believe it or not, housing insecurity, and things that we would not think pre-COVID. Especially among our cancer patients. So I don't know. I don't have a good answer because the promise measures are very brief. You can use 6 items to screen for anxiety and depression, but that doesn't really give you much information other than as a general screener. So obviously the screener question versus the, okay, this is something actionable that I know what to do with and who to refer to. So for our survivorship center, we're trying to come up with like a set of items that both look at social determinants and things that are more practical needs, things that are support needs, and then things that are psychosocial needs. I don't know if that helps you any, but I don't think there's any consensus on patient-reported outcomes, sadly. And I think our GYN patients deal with so many symptoms that neuropathy being one key one, and being functional and fears about being able to function in their job, that some of the practical worries come to the forefront.
Sally and Eva, Eva Marie, do you have any sort of comments from a patient perspective? Because some of these tools are quite weighty, and also, I suppose my concern as a clinician is how we actually get that information to us in a distilled fashion, and then that we can act and get back out to the people that can help people. I don't know if you've got any thoughts.
That's me?
Yes, Sally, that'd be great.
Okay, I would say that patient support groups would work very well. So when the survivors meet for their normal, maybe monthly or weekly meeting, or depending how often they meet, then they could gather this information and once in a while call the expertise to come to the group and share with them, or just write a report and give it to them and follow up that this is happening and whatever issues have been raised have been tackled. Yeah.
Yeah, well, that's a really good point. Eva Marie, do you want to add anything?
Yes, I should say the same thing, that the peer support group and the discussion group, they are really, really good for the patient, and also that the clinician or the doctor can come there and talk and get the information they need also from the patient. It's important to get straight away from the patient. It could work. Yes, I think so. And also to have some questionnaire before appointments, it would be really, really good that the patient could by themselves think, what do I struggle with right now? Is it the economic problems? Do I have problems eating? Is it the sexuality? What's my problems really right now, before the appointment with the doctor? Then it's easier also to come to the doctor with the paper or to say that here's my 3 biggest issues right now. And then the doctor could talk to the patient about those issues.
Yeah, absolutely. I think it's really interesting to look at how women can be empowered, as you say, to ask those questions that are important to them. And sometimes that means knowing that other people have those problems as well, and it's okay to talk about them. And I think that was something, Sally, that you touched on in your talk as well, about information and as you say, there's opportunities when maybe women are coming into the healthcare system for another reason, but we could actually, be giving this information and helping prior to any diagnosis with screening, but also after the diagnosis. And I think the points that you made about managing, stomas and things like that, and the stigmas that come with that, incredibly important. And I just wonder, some of the questions have been, how do we reach vulnerable and underserved populations, not just in low and middle income countries? I think we've seen in high income countries, as Sharon pointed out, a huge group of people who are not on the internet, maybe not wanting to come forward and voice some of these concerns. And do you think there's something that we could do as an international group to help with kind of information aids and raising awareness?
I really agree that there's a digital divide, and I didn't believe that until obviously in other countries. But in New Jersey, I was stunned by how many patients are seen in our center that can't get through the portal. So it's a broader issue than just, distress screening and providing resources to our patients. Increasingly, with Epic and all sorts of patient portals, the patient themselves are going to have to use it. So it's a broader issue. I don't know how to address it. I do know that it's significant in the United States.
Sally and Ava Marie, do you want to add anything? No, that's fine. There was a specific question for you, Sharon, about whether you found that gynecological cancer patients were different in their needs from other patients.
Yeah, actually they are. So I work with breast cancer in my research and prostate cancer, and I think because of the nature of the disease being obviously much less studied, it's very different in terms of treatment approaches and what we know. The risk for recurrence being so much higher, disease being diagnosed later. For some patients, we know that there are pre-existing factors. Endometrial patients tend to be obese or overweight. So there are things that are really make the patients different just from the very start. I also would like to note that they're very different from breast cancer patients with regard to the availability and maybe stigma around psychosocial care. There are sexuality concerns that are very, very different. There are some very unique concerns regarding intravaginal radiation that I've come across that are so different because I've had some assault survivors. Believe of the 10 people, 3 people have been assaulted. So you can imagine the kind of issues that they face. So I have to say, in my many years of working with this population, it's the population I feel is very, well, I mean, head and neck as well, of course, but that they have some very unique needs. Now, again, I'm not a general clinician. I'm a research clinician, so my familiarity is just with the populations I've worked with.
Thank you. And Ramunda, we had another question as well, specifically about components of palliative care that were important for the families and what we can do to help support families.
Well, again, thank you for the question. I think we do not have any structure for the family in the sense that I think we are behind that step. We need to work on the importance of palliative care, early integration, multidisciplinary approach. Having said that, the focus in family members and caregivers are from the psychosocial support, and there is some work done there. But another thing that we do not have here in my country, but there is in Canada, and I hope many countries will adopt this, is to give a leave for caregivers. And I think that could be a great support for family members and caregivers. It is difficult. It needs a structure. Not all caregivers, family members can take care of the patient at the same time. But I think each country should work on that and should have some sort of leave for the caregivers and family members. If it is possible, it will be a great help for both the patient and the caregiver.
Thank you. We'd also had some questions, particularly about sort of telehealth visits that have happened through COVID, maybe changes in follow-up and surveillance getting longer between visits, and wondering what's going to happen as we move, hopefully, beyond COVID. I don't know, Ava Marie and Sally, what are your thoughts about televisits and telephone consultations?
Yes, it's good and it's bad. It depends on the patient, of course, and the doctor and the symptoms and the appointment. If you just have to discuss something, it could be good with the telephone or the video conference or something like that. But if you want to show something and you have to get the checkup, of course, it should be with the doctor's appointment, and that's really important. And I also want to say something about the small children, because quality of life and the survivorship is always, you think about the patient, but in the family could be also small children and children. So you have to think about them also, and they need also the support to get through the crisis they got, because it's a different psychological crisis they have. So that's just one point.
Yeah, it's a very good point. Sally?
Yeah, just to add on what Eva says, it's a challenge, and we must appreciate that a lot has happened since last year when we had COVID, and meetings are still going on virtually. But again, you find that I would talk for my country. There are so many people who do not have just a simple mobile phone. So talking of a smartphone, that is luxury. That is like a joke to them. They don't even know what you're talking about. So I've seen that a lot of people have missed their appointments and they have to borrow, and that means you have to disclose your status if you hadn't disclosed. If you're living with a chronic condition and you can't go for your appointment, and you have to meet with your doctor through a Zoom meeting, then it means you have to borrow a phone. And so it means you're disclosing with something that you didn't want to, maybe you're not ready to disclose. So COVID has come with its challenges, but just as HIV, it is a virus. So we have to just put systems in place that we're going to live with it. So how do we manage ourselves? Because it's not something that is going away tomorrow. So just the same way we manage HIV, I think governments should think of systems on how we will live with COVID, because it is here to stay.
Absolutely, yeah.
And I just want to add also about the screenings. I know here in Finland and many countries, the COVID has done very bad things to the screening programs. So I have tried with my association and by myself to say to all women that go to the screening, don't be afraid for the COVID, put your mask on, and it's safe to go to the screening. So I think this is a big message that you have to say to every woman.
I would agree. I have 2 patients on trial who were bleeding and did not and hesitated to go in. Now, of course, treatment delay for screenings. What screenings are there for ovarian cancer, really? But when they're having signs and symptoms, the patients were afraid to go in because of COVID, and I think it's going to lead to even more later stage and higher mortality rates in all cancers. But it's just really sad to see, and I'm sure we're all aware of that by now.
Raimondo.
Yes, well, I think all of you, I agree with you that COVID has pros and cons. I would like to share with you and with the people who are listening us this morning my experience taking care of patients with COVID and end of life. We not only my team, many palliative care teams took care of patients with COVID who died of COVID, elderly people, and it was a great opportunity for me, for many colleagues, to give them the opportunity to die with dignity. Hospitals here in Chile were full. Unfortunately, some people died in the emergency room. Families didn't know until 2 or 3 days later. So in order to have a room with 3, 4, 5 beds and let them die with dignity was a great opportunity for me, but also for the patients and their families. So that was a good assistance that palliative care put for COVID patients. Also, I know Sally just mentioned that most of people in Africa do not have cell phones. Also, they don't have smartphones. But for those places where smartphones are available, I think it is a good help to put in contact all of us virtually. And this is something good that I agree we could not apply to all the world because smartphones are not available worldwide.
Thank you very much for everyone. I think just as we're drawing to the close, I would just ask each of our panelists if they just want to make one more comment or sum up on anything from today's session. I don't know, Sharon, do you want to start? I've maybe lost Sharon. She's frozen. So, Ava Maria, do you want to start with something?
I just took my picture off because it froze. I would say that psychological care is just really important. That it's been my experience that patients do not seek it out on their own, but that about a quarter of the people suffer some type of psychological distress, particularly if you include really elevated levels of fear of recurrence, and that we do have evidence-based treatments that I really hope over time become more accessible to patients who are on and off treatment.
Thank you. Ava Maria.
Yes, thank you. I think it's important for the cancer patients to really have the doctors to listen to them and take their concerns seriously and symptoms and worries. And also they need a rehabilitation plan or a survival plan. Also, they need a diagnosis curator to help the patient right after the diagnosis, and the psychological support and discussion groups and discussion about fertility and sexuality issues is really important, and to find the peer support groups and possible to chat or to meet other patients in the same situation, it's important. So I think there's a lot really done, but it's a lot you can do. Thank you.
Thank you very much. And Sally.
Okay, for me, I would say that a lot has been discussed in this forum, and please let us implement whatever has been discussed, because we talk a lot and say all these good things and then it's left on paper. So can we implement this? And I would also want to say for those the audience who are listening to us, maybe you haven't gone for any screening, do not wait for pain, because sometimes cancer does not pain. Personally, I didn't have any symptoms, I didn't have any pain, but I was told I had stage 2. So do not wait for pain. Thank you.
Thank you, Sally. Yes. And Raimundo.
It is difficult for me to say in just one word, but I will be short. The care of a patient with cancer is a human right. So we need to take care of her and the corresponding family members and caregivers. For gynae patients, and for all cancer patients, there is still many things to do, and we need to keep improving in overall survival, but we need to take seriously PROMs and quality of life. And a call for patients and caregivers, please don't be shy and ask for your supportive oncology or palliative care team. Thank you very much, and congratulations to all panelists today.
And I would like to say a huge thank you to all our panelists and for sharing their expertise and their experiences. And I think, Sally, you've made a really good point. We talk about these things a lot, but we need to move forwards and see what we can do together. And maybe we need a brainstorming session where we aim to actually come out with some tools, some education. I think the IGCS palliative care module for clinicians is great, but we want tools to inform and empower women as well, that we can then adapt for different cultures, different settings, different resource settings. Because as you say, smartphones can be fantastic for those that have them. So we should use that technology, but we need to then think also about those that don't. So I want to thank all the participants who've joined us. So many have stayed on till the end. So thank you very much. And if you want to, add your thoughts following this, I think that would be really useful as well. And I'd also like to say a large thank you to our sponsor, GSK, who've made these roundtables possible and helped us to connect women across the world. So there will be a fourth one, which will be held on Friday, the 15th of October. So please save the date for that as well. That's going to focus on global health equity, which I think is just an incredibly important issue for us to discuss. So once again, thank you to all our speakers. You've been amazing. Thank you for attending. And I wish you all continued health and safety in these difficult times. Thank you.
Thank you, everybody.
Thank you.